Good morning, good afternoon, good evening, everyone. Thank you so much for joining our ACNS webinars today. So today our chair is Professor Constantine, who is the Professor in Neurosurgery of the Department of Neurosurgery, the Jikai University School of Medicine in Tokyo in Japan. So today we'll have three speakers. The first one is Professor Yaji. We'll be talking about the bioengineering of intracranial aneurysms, the mechanism and prediction. Our second YNS speaker is Dr. Dragan Janovic, who will be talking about multiple glioblastomas. Our expert speaker today is Professor Xin-Yu Jin, who will be talking about sharp dissection and drilling technology in skull-based surgeries. Our discussant today is Professor Otani Sensei, who is the Clinical Professor, Division of Neurosurgical Surgery, Department of Neurosurgery, Nippon University School of Medicine, Vice President and Chief Manager, Center of Brain Tumor and Skull-Based Lesions of Nippon University in Japan, and also Professor Prissett, who is the Professor of Kabul University of Medical Sciences. So to moderate the sections today, we have Sachin and also Dr. Teague and Dr. Sugiti, and also Joey San with me. So without further delay, shall I invite our chair, Professor Constantine, to introduce our first speaker. Please, Professor Constantine.
Thank you, Ben. Good afternoon and good evening to all participants. It is honor to be chairing this session. So thank you very much for choosing. Now we have three speakers today, very diverse subjects. The first one is from Professor Yagi, who has dedicated his investigations and his talk today to a subject which is related to the basic flow dynamics and pathophysiology of aneurysms. This is a very, very important section of the analysis of aneurysm growth and aneurysm origin. So currently we will have a very important subject for discussion. I invite Professor Yagi to the floor. Welcome.
Thank you. Oh, so shall we get started already?
Yes, please.
Okay. Thank you, Professor. Nice introduction. All right. I hope you see my presentation clearly and hear me very well.
Yes.
My name is Yagi. I'm an engineer. Been doing this research about intracranial aneurysm, Y rupture. And more specifically, we are interested in the Y wall being thinning or either thickening, this kind of thing, in any way that better understanding of the Y rupture. And eventually, engineers want to get under control, meaning under prediction. So, all right, let's get started. So my contents, first, I introduced the review on what is the rupture mechanism at this moment, hypothetical. I briefly explain. And after that, I introduced our recent research. And recent research is categorized at the first level is the wall thickness. Like a thin baby aneurysms looks like this usually. It's a red color, meaning that the wall is thinning compared to the surrounding part. And a big one, a middle-sized one, 5 millimeter, 7 millimeter, the walls typically looks like this: white, non-translucent, and red, translucent. So two types of possible mechanism being involved, which is the wall thinning, like this one, wall thinning from here to here, or either wall thickening. Okay. So what is the quantitative discussion of what is the wall thickness? And after that, in the pathological level, we compare the thin wall and thick wall, and then discussing the mechanism. And also that those aneurysmal remodeling being believed to is related with wall mechanics. Wall mechanics is one part is related with blood pressure and hemodynamics. Okay. So before talking about the worldwide well-known hypothesis, this is a study done by a Finnish study, Finnish group. They categorize aneurysmal wall tissues into the 4 types, A to B to C to D. And they qualitatively categorize A to C type, thick wall, like thick wall. And the D type is a thin wall. This is a wall, okay? And smooth muscle cells are, yes, rich smooth muscle cells, rich smooth muscle cells, and less smooth muscle cells are less smooth muscle cells. And they also observed that a thrombus, A type without thrombus, okay, without, and the B to D with thrombus. And most importantly, they observed thin wall without smooth muscle cells with thrombus. This case, 100% in ruptured aneurysm. Okay, so that basically their hypothesis is pretty much they emphasize that the role of thrombus. Okay. So this is what they categorize, what we call flow-induced, okay, inflammation-mediated wall remodeling in the formation and progression. Like they observed that the thrombus on top of that array of wall layer without smooth muscle cells, so that basically their luminal thrombus is a trigger of sort of the smooth muscle cells death, loss of neural cells, smooth muscle cells death, okay? So that the luminal thrombus either through oxidative stress or proteolysis, and then the wall cells are dead and the matrix degenerated. This is how they, where is Castle? This is why they say that the rupture is going. And why that the luminal thrombus is what they currently been thinking is that high wall shear stress, high flow. High flow is creating the dysfunctional phenotype of endothelial cells. So injured endothelial cells that recruit macrophage and repeat into the wall. So this kind of the intimal dysfunction is the underlying conditions of media functions, okay? However, we are believing that the current school of theory is only discussing the pathway of wall degeneration, injury. Back to this one, is everything this wall relating to the wall injury, not repair. So where is that wall regeneration, wall repair? Because we found that non-translucent and translucent, this kind of the 2 distinct remodeling has to be involved, both injury and repair. However, current school of theory doesn't consider a regeneration repair. And the current school of theory only focuses on hemodynamics and ignores the role of blood pressure, okay? So that this slide is, playing the key part of this presentation. I titled that the thickness matters, and the thin wall act like hypertension. This is a cross-sectional view of the vascular wall. 2 types of the mechanical forces acting to the vessel wall. One is the blood pressure, and one is the shear stress. And they are focusing on the blood pressure, then phenomena like this. Blood pressure and has to be balanced with the wall stress, sigma theta. And in the mechanical course, in the engineering way, and blood pressure P, sigma theta in balance like this formula. Sigma theta is a wall stress. T is thickness, okay? Thickness. R is radius. P is blood pressure. So that if the pressure that, just normal pressure, but that a thickness reduced, then wall stress is inversely increased. Okay, so the wall getting thinner and thinner, meaning higher wall stress. And of course, is that the uniform thickness, higher blood pressure, of course, sigma theta is elevated. But even in the same blood pressure, thickness getting reduced, then sigma theta is increased. This is a kind of like a wave hypertension, okay? And the smooth muscle cells is known to react with the blood pressure, sigma theta. And by changing the biomechanical forces around the smooth muscle cells, they changing the phenotype, contractile, synthetic, and the cell death. This is a key point in the aneurysmal rupture. Especially apoptosis is being induced by changing the wall stress. Okay, so contractile, synthetic, and even apoptosis. Okay, being related with the mechanical environment. So this is a typical result of the three-dimensional wall thickness. Three-dimensional wall thickness of unruptured intracranial aneurysm. And this blood dotted line is that we harvested with neurosurgeons. And the same orientation, we actually dry the tissue and put it to the micro CT and measure the wall thickness three-dimensionally. And the 1 is meaning 1, 2, 2, 3, 3, the same orientation. And this part is translucent, and the other part is non-translucent. And see, this part is wall thickness crossing to the 20 to 30 micrometer. Okay, micrometer. And this part is containing wall thickness, kind of like a 300 to 400 micrometer. And this transitional part, very interestingly, like focal thin, focal spot, focal thin, focal spot. This kind of undulated profile of wall thickness we can observe. This is a very typical result in the translucent and non-translucent walls of wall thickness. Okay. So that let's get a little bit summary of what is the wall thickness of unruptured aneurysm. The thickness is categorized the 3 regions: thin wall, transition wall, and thick wall. And thin wall is 10 to 40 micrometer. The thickness pretty uniform profile. And transition wall, kind of like this part, is undulated, focus thick and focus thin. And thick wall is a peaked profile, 3 to 500 micrometer. So that typically with this very small region, wall thickness changed 30 times, 40 times with this order. This meaning is that even in the same pressure, blood pressure, same radius, but different thickness, meaning that the wall stress around here, around here, around here is buried 30 to 40 times, okay? And obviously that here the wall thin wall is exposed to the higher wall stress compared to the thicker wall, okay? And one very, very nice study from mechanical point of view, they compared, they put the harvested tissue into the testing machine, and they produce a stretch, and they measure the stress. And this is the aneurysmal tissues compared to the normal control arteries. Focusing this is that if we gradually get stretched, then at certain point, wall is broken, okay? That stress we call ultimate stress. Ultimate stress is the maximum stress, which is about 1.4 megapascal. So put into the 1.4 megapascal into sigma theta, and say P 100 millimercury, R is typically 2.5 millimeter, then we can estimate thickness around 20 micrometer. 20 micrometer is very typical thin wall thickness. So which meaning this wall thinning, thin wall is due to mechanical failure in response to blood pressure. Okay, thin wall, this kind of uniform profile. So that back to that missing point, the current school of theory only discussing the pathway of wall degeneration injury. And the wall degeneration injury is being linked with hemodynamics. But we say this isn't. We say that the wall degeneration injury is related with blood pressure. Okay, blood pressure. And the later part of this presentation with the wall regeneration repair is linked with hemodynamics. I introduce later on. So we compare that thin wall, thick wall in the level of ultrastructure using the transmission electron micrography. And we categorize basically the 3 layers. One is what we call migratory layer. Migratory layer is like very fresh thrombus layer. Scattered but very active smooth muscle cells and surrounded with numerous cell deaths. And platelet, fibrin, monocyte, macrophage, sometimes neutrophils, very rich cell types exist. And most importantly, this layer is without any collagenous fiber, okay? And the second type is what we call proliferative layer, high density, multi-directional smooth muscle cells, okay? And most importantly, dense collagenous fibrils, right? Dense, this part is collagenous fibrils. And the third part is this layer, what we call necrotic layer. Unidirectional, this is very important. Unidirectional necrotic smooth muscle cells. And the term necrosis we use to describe this part according to this cell death very well-known journal. They categorize 2 parts, oncosis, apoptosis, and depending on the level of cell death, necrosis before, after cell death, okay? But anyway, this kind of we call necrotic layer. And the type of cell death, this is very important, is apoptosis, okay? Dense collagenous fibrils similar to this proliferative layer, but the cell is dead through apoptosis. And creating the apoptosis, creating the pore, and sometimes cavity, because the pore is connected, and microscopic tears, kind of like this. This kind of categorization we did. And we compared about 7 cases. Most important thing is that look at this one. And this is a very typical mono layer of necrotic layer, mono and necrotic layer. This part and this part. The presence of simple mono layer and necrotic monolayer, meaning a lot. Because that thrombus being believed to creating that wall thinning, but we observed thin wall without any thrombus. Okay, so thrombus either a result of wall degeneration or cause of wall degeneration. This is matters. And currently being believed is that the thrombus is a cause of wall injury. But we say thrombus is a result of wall injury, okay? This is a very important point. And the thicker wall, like this one, and or this kind of thing, is that multi-layer. Multi-layer is that the surface and like the middle and outer is a migratory, proliferative, necrotic, mixed, everything mixed. So, like depending on that level, the cells express a totally distinct patterns in ultrastructure level. Okay. So we compared the previous studies in terms of first of all, endothelialization. Endothelial cells is very playing the key role because they have a sensing ability of wall shear stress. And being believed high wall shear stress is dysfunctional endothelial cells, dysfunctional endothelial cells recruit monocytes change to the macrophage. This is a very, very underlying condition being believed. But unfortunately, at this our research, we hardly to see, or even I never ever found this kind of a figure over the last 10 decades. Okay. And the covered level probability of endothelialization, we location specifically about only 15%, and cases specifically about 30%. Compared to the previous study says old study 7%, 70%, and recent study only 44%. So that currently I believe that most of the wall of unruptured intracranial aneurysm is lacking in endothelial cells. With this graph, endothelial wall is only this one and this one and this one. Okay, that's it. Even all of this is without endothelial cells. Okay, without endothelial cells, no way to respond to the wall shear stress. Okay. And the second comparison with the macrophage. Macrophage location specifically we found 40%. Cases specifically about 85%. So macrophage is a very typical cells in unruptured unruptured intracranial aneurysm. However, the point is that where is the layer? We found migratory layer 100%. Like migratory layer like this one is without any collagenous fiber compared to the dense layer. Dense layer is here. It's very dense collagenous fibrils, but the migratory layer is very sparse, rich blood cells like platelet, fibrin, kind of thing. With this layer, macrophage we can observe. And the proliferative layer down to the little bit one down, then get reduced. And even here, nothing. So that the monocyte macrophage there, of course, exists, but mostly in the, this migratory layer, meaning mostly related with luminal thrombus. Okay, luminal thrombus contains macrophage, monocyte, kind of like inflammatory phenomena. Okay, and without with this typical like cells elongated, proliferative, or as a cell death, this kind of dense collagenous fibrils layer doesn't have any monocyte. Okay. So this investigation clearly saying that the thrombus is a part of wall repair, not part of wall injury. Okay. And lipid, Finnish study, they said that the lipids they frequently observed, but this study we done in Japanese population, and a lipid rather smooth muscle cells kind of like this one, they found in Finnish samples, we hardly to see. Of course, sometimes the lipid exists and engulfed by the monocyte or macrophage, but not the level of smooth muscle cells. So that we like to propose that theory, injury. Basically, that the injury is related to smooth muscle cell death. And they are creating the cell death because of the smooth muscle cells we currently believe reduced by apoptosis being reduced by higher amount of wall stress. Okay, because wall thin wall, hypertension, creating the bigger wall stress triggers smooth muscle cells death, clustered death. Cluster. This is a very, very important topic. These cells, like this one, everything this smooth muscle cells is dead through apoptosis. Because of the mechanical forces elevated locally, so that the local smooth muscle cells as a populated, as a clustered death, okay? This kind of death is leaves pore, and the pore is connected to cavity like this one, bigger hole, and even bigger like a microscopic tear. So this kind of like an internal collapse, okay? Not external collapse, internal collapse due to the massive cell death. This is what we currently believe the injury is being induced like this one, okay? And what is the repair? Repair, we know that the hemodynamics is related with thin wall, thicker wall. This kind of thin wall, thicker wall, thin wall, thicker wall, thin, thicker wall. This thin walls is coincided with the location of flow impingement. Like flow impinge, right? Flow like behaving like a divergent types, or this like a true 100% impinging is almost 90% is coincided with translucent wall, and like merging flow, like rotational flow, meaning like more stationary flow, is nothing related with translucent walls. Is either hyperplastic, like white wall, or either atherosclerosis, yellowish wall. Okay. So that the flow, first of the repair is related with the luminous thrombus, and the hemodynamics is being believed with has a role of preventing the engraftment thrombus. So flow impingement by inhibiting engraftment of luminous thrombus then leaves wall keep injured. Okay, and the flow stasis support the engraftment wall, luminal thrombus, then assisting the wall thickening. Okay. So this is a slides what we've been currently believed. This formula: thickness, blood pressure, radius, wall stress, either thicker thin wall, elevated wall stress, then creating the smooth muscle cell death. Then this leaves pore cavity tear kind of like this, internal collapse. Then in this condition, if the wall exposes the high flow, then meanings without any luminous thrombus, then the wall is simply monolayer of necrotic layer. Or low flow, stationary flow, then allowing the luminous thrombus engrafted. And then a luminous thrombus is creating the lot of cytokines and produce smooth muscle proliferations, okay? So like this is related to blood pressure. This is related with hemodynamics. So that blood pressure is praising the underlying role of wall injury, and hemodynamics is more related with wall repair. Okay. So this is our last slide. Let's study. This is a typical histology of ruptured aneurysm, and this is a ruptured point. And this is fresh thrombus. This is a thick fibrous tissues. So before rupture, like this kind of tear, before rupture, this part is a thicker wall. This is a thin wall, thick wall, thin wall, thick wall, thin, thick. This kind of thin, thick, thin, thick, thin, thick. And the thin walls always expose the higher amount of wall stress compared to this part. So this higher amount of wall stress eventually creating the local injury, then giving the chance to be thrombus. Thrombus meaning like this layer, okay, this layer. And with this thin, thick wall, creating the wall stress concentration between the thin and thick wall, this part is inducing the more risk of rupture. Okay, that's it. So this is my presentation. Thank you for staying with me. Thank you.
Thank you very much, Professor Yagi. It was a very interesting presentation, raising so many interesting ideas and questions, most probably in all our participants. My congratulations for this idea of having really a theory of the growth and rupture of aneurysms, because this has been really puzzling the whole community of aneurysm investigators. Definitely, or unfortunately to say, at the moment we cannot assess by some morphological study. It is practically very difficult, and most probably, hopefully, in the future, we will be able to assess by MR or some other kind of digital imaging the thickness of the aneurysm. And in this way, we will be able to prognosticate the risk of rupture, not only by the criteria that we have established, let us say, by the cooperative study, UCAS, and so on. But again, many interesting findings. First of all, I would like to ask about the definitely elasticity is extremely important, but the formation of a thrombus is a process in which we need, to some extent, slowing of the flow and some kind of stagnation, not only endothelial injury. What is the correlation between the interaneurysmal flow dynamics and the areas of thrombus formation?
Okay. Right.
You mentioned a little bit about that, but
sorry, I missed the last bit.
I will repeat it. How is the relationship between the interaneurysmal flow dynamics and the location of the thrombus formation? You mentioned a little bit about the types of flow inside the aneurysms, but that is not an uniform actually process. We have some places with thrombus, some places without thrombus. Exactly on this slide, yes.
Yeah, let's see this part. This part is at a location flow impingement point. And this part is exposed to the full impingement, okay? Not partial.
I mean, against the flow, against the streamlines.
Yeah.
Okay.
Then we see never luminal thrombus, just a bit like basal membrane directly exposed the blood without any cells.
Well,
and some part
that gives some explanation, because outside the flow we have a slowing of the speed of the flow, and that will create better conditions for aggregation and further thrombus formation.
Exactly.
Yep. Okay, thank you very much for that. Well, if there are any other questions from the audience.
May I question?
Yes, thank you very much for discussing importance. Is very important, the point.
May I question?
Yes, we are welcome.
Thank you, Professor Yagi, for your so interesting research contents. So my question is, so I am very surprised your results or thin type with lacking of smooth muscle with thrombus is 100% ruptured. It's just only for the sacral aneurysm theories. It's just only for the sacral type of the aneurysms. So my question is, it's mimicking the dissection of the, the dissectional dissecting aneurysms. So it's your theory is can your theory is mimic the dissective aneurysms? So my question is, where is the existence of the thrombus? Is where is inner membrane or the media membranes or outer membranes? So where is the existence of the thrombus?
Thrombus, what I'm saying here is that the inner membrane.
Just inner membrane.
Just inner, luminal thrombus, inner, not media, not inside, just innermost layer.
And so I think is so the mechanism of the enlarged the thrombosed giant aneurysms. So it's related with vas bathroom, vas bathroom. So, but in your series, not so commented related to the vas bathroom. But how do you think?
In our data, unfortunately, the size of the aneurysm is not that big. Like biggest one is about 5 to 6 millimeter. So that we currently like a big one, like a thrombus aneurysm, like a very complex aneurysm, hasn't been not enrolled. So this is why I couldn't say the role of vas bathroom or like let's say that the thrombus in media type of things as a more like seemingly like a more bigger like a wall injury, then creating the like let's say like a microscopic tear I can observe inside, and if the microscopic tear happened like a bigger way, then creating the thrombus into the media, then this kind of the injury creating the big loss of balance of mechanical point of view, then possibly being grown to the more complex, theory of what you say. Yeah.
And so how do you think about the the activity of the wall activity induced by the inflammatory agent? So how do we enhanced dural enhancements? We usually check the dural enhancement for the ruptured arteries. So how do you think about the activity of the inflammatory activity of the wall, vascular aneurysm wall? Do you think about
inflammatory reactions about 15 years ago from the United States, they are discussing that a macrophage into M1 and M2 phenotype. And this is not, this is still like in the stage of controversial, but M1 and M2 macrophage, two types of distinct phenotype, creating the M1 is for injury, M2 for repair. This is very typical understanding in abdominal aortic aneurysm. But this kind of the role of macrophage phenotype in intracranial aneurysm hasn't yet done. But my data, my more like monocyte macrophage in like a thrombus layer, this observation clearly saying macrophage not more like related with wall injury or simply a part of wall thrombus. So meaning wall repair.
Thank you.
But M1, M2 phenotype, this kind of things, unfortunately, using the transmission electron micrography, we are harder to say. So yeah, this is still a controversial topic. Okay.
Yeah. Thank you. Thank you so much.
Thank you. Thank you very much,
Dr. Ben.
Is there any question is that?
Sorry. Thank you. Yeah, perfect. Sorry.
Is your line on?
Sorry, am I audible?
Yes, you are.
So I was just trying if Professor Pizat is online, but apparently he's not. Well, due to constraints of time, we have to proceed with our next talk. He is from... Yes, please.
Ben Sensei is raise a hand.
Yes.
Ben?
Yes.
Okay. Just a quick question. Thank you, Professor Yagi, for your great presentation and really nice understanding of the aneurysm. I just want to ask about in your opinion, any study of those aneurysm with calcification or fusiform aneurysm in your experience? Thank you.
Yes, calcification is currently the hot topic in the United States, and in our population, in our data, we only sometimes calcify the part. Not sure. This is a result of that because the United States, they say that the more high amount of calcification could be related with the distinct population, United States or Japan, but hard to say at this moment. But only I can say is in our data is I very, very rarely see calcification in our Japanese data. And the huge form, unfortunately, that the huge form data is enrolled. So yeah, it's very hard to say at this moment. Only circular.
Again, thank you, sir.
Okay. Thank you, Professor Yagi.
Is
Is there
one
any
more?
other question? Yes, please.
Kimura-sensei?
Yes, please.
Thank you, Raja. So, thank you, Professor Yagi. Excellent presentation. So I learned a lot so much. So I know I've learned so much from your past literature, from your published data. So today you mentioned about the high work stress according to first the high work stress according to annual smooth muscle cell depletion, and according to annual wall thinning. You mean, right?
What I'm saying is that smooth muscle cell death and or wall thinning, kind of like these phenomena are all related with blood pressure.
Blood pressure.
Not wall stress.
I see.
And because of the wall stress is only acting for the inner layer, and the amount of wall stress and amount of wall stress is totally different. They vary by the order of 10 to the fourth power. Totally different. Okay.
Yeah, I see.
So
I see. Pressure and you mean the pressure and wall stress is totally different. You mean?
Yes.
Yes, I understand. So I also
And
so please go ahead. Thank you.
Yeah. So that the smooth muscle related is the blood pressure and the matter of the either thrombus or non-thrombus, because the thrombus has to aggregate blood cells or fibrin. This kind of thing is that related with hemodynamics.
I see.
So higher amount of wall stress, like I wouldn't say higher amount of wall stress. Currently, I say that flow impingement at least. At least flow impingement is that has a function of inhibiting aggregate of blood cells or fibrin. So inhibitory factor wall repair. This is my point.
Yeah, finally, the point is flow impingement point according to aneurysm wall thinning, you mean?
Yeah.
So where the oscillatory shear index may be decreased at a point. For example, my research from a computational fluid dynamic research. I also a researcher for computational fluid dynamic, and my point as my result of my study is a flow stagnation point is according to aneurysm wall thickening, and it's a bit very similar to your presentation, your findings, and the less stagnation point is according to the aneurysm wall thinning. So I just a little bit confused today, but you give me a solution. Pressure is wall shear stress totally different. But we have to clarify the difference. Yeah, thank you.
Simply saying that the blood pressure is the primary load, and the hemodynamics is a secondary, like influential factor.
Yeah, I see. Yeah, thank you. Thank you so much.
Yes, thank you. That was very important. The last few words, really. Thank you. Dr. Shanawaz, do you have a question, please?
Yeah, well, thank you, Sensei, for the opportunity. Based upon this experimental study for ruptured and unruptured aneurysm, what clinical importance it bears for neurosurgeons?
Sorry, I missed a point. Bears.
We have a ruptured aneurysm in surgery. What importance will this experimental study bear for the neurosurgeon? And number two, for a patient with incidental finding of aneurysm, in that case, what clinical importance we can have from this study?
Yeah.
I mean, for aneurysm, either ruptured or unruptured, as a neurosurgeon, what clinical or surgical importance I can have from your study?
Any message for clinical practice, Dr. Yagi?
Any message for clinical people?
Yes,
it's
for
really hard to
clinical
say.
practice. Yes. This was actually the summary of the question to say.
動脈瘤を考えたときに、破れてようが破れてまいがですね、先生の研究はどのように役立つんでしょうかということですね。
Okay. Basically, we like to stop wall thinning. So that in order to stop wall thinning, is that the best way is to get every layer of wall is being thrombus. So control of thrombus. This kind of be a future topic of the therapeutic topic for that changing the thin wall to thicker wall. In order to do that, currently we focusing on that understand the mechanism. So this is a long way to go, but the direction we should go is that control the thrombus. Yeah.
Thank you very much.
Concurrently,
I think that was a very clear message.
Okay, as we have a senior neurosurgeon and also Professor Kato Sensei here, just one concurrent question. Like aneurysm clipping, when there is dissecting aneurysm like the M1 bifurcation aneurysm, sometimes part of the aneurysm is thrombosed and part of the aneurysm is a blister. And we often don't clip that thrombosed part because it would obstruct the flow in the M2. From this study, the thrombotic site is very critical. So, what are the inference we can get now?
Remember that last question was asked at dissection. And dissection, and obviously in our data, it's non-dissection case. And the thrombus meaning a lot, I think, in the light injury or heavy injury. And in dissection, like you said, the thrombus aneurysm is experience already that heavier injury at some point of time. Then they are covered with the thrombus into the middle layer. This kind of things, I don't talking about this one. What I'm saying is small injury, only surface, and the surface has to be gradually thrombus. But specifically, I'm talking about right injury, okay?
Okay. Yeah. Thank you, Sensei.
Thank you very much, Professor Yagi. You have been really raising very, very interesting points, which we expect that will have implications into our clinical practice in the next years. Wishing you success with your studies.
Thank you.
I'm sorry, we have to proceed because of time constraints in our second speaker. This is Dr. from Mainz. He is a resident at the Department of Surgery there. And his topic today is multiple gliomas. That is a very interesting subject for the analysis and for the management, for even the pathophysiological mechanisms that stay behind the presence of glioblastomas in that way. So we will be happy to hear later from him. Please, you have the
Try again.
Do you hear me?
Please unmute yourself.
Yes, we're hearing you.
Okay,
Yes.
thank you very much for the invitation for this webinar. I'm Dragan Jankovic, the fellow from Fujita, from Professor Kato, and also a resident here in the Mainz in Germany. I'm here part of our neuro-oncological team, a research team, and today I will present our recent data that we present on the CNS annual meeting in September in Washington, D.C. So then I will start. I just want to show where is Mainz. It's in Europe, in the middle of Germany, and here is our university and our hospital, and here's entry. And I start. So I have nothing to disclose today for this topic. Glioblastoma is devastating and universally fatal disease which can occur in a form of solitary or multiple lesions at the time of the diagnosis. And the median progression free PFS and overall survival are dismal at only 7.4 months and 15 months respectively. What's important that reported incidence of glioblastoma with multiple lesions differs between 2 and 35%, and literature stated that overall survival is believed to be worse for glioblastoma with multiple locations. Multiple tumors, location tumors can be further distinguished based on the presence or absence of an imaging connection between contrast enhancing lesions, and those with a visible imaging connection that we see in the FLAIR segments are termed multifocal, and those with separate foci as multicentric. What's also important that tumor heterogeneity is considered a hallmark of glioblastoma, and tumor cell plasticity contributes to the complexity. And we know today that multifocal tumors genetically resemble solitary glioblastoma, and analysis from various studies and from literature of multiple foci from a single patient revealed monoclonal origin. When we talk about glioblastoma, we have here in Germany one gold standard of glioblastoma treatment consists of maximal safe resection, surgical resection, followed by radiotherapy and alkylating chemotherapy with temozolomide. Greater extent of resection has been shown to be associated with improved survival grade in high-grade glioblastomas, and gross total resection of more than 85% of tumor volume is superior to lesser degrees of resection. Also, in addition, extent of resection improves the efficiency of adjuvant radiation and chemotherapy by reducing disease burden and improving chemotherapy patency and longevity. And up to date, and that's the reason why we performed this study, up to date we don't have accurate data on the impact of the extent of resection in tumors with these multiple lesions. And the aim of our study was to evaluate the role of multimodal treatment in the multifocal and multicentric glioblastoma, also correlation with the single lesions and its correlation with progression-free survival and overall survival. So it's the reason why we performed this study, and we performed that as retrospective study at 2 major academic departments in Germany. We included all patients treated surgically between 2008 and 2020 for multifocal or multicentric glioblastomas, baseline characteristics such as age, sex, functional and neurological status at admission and discharge using Karnofsky performance score, and also ACOG. ACOG is Eastern Cooperative Oncology Group performance status. Were analyzed. We also analyzed radiological and molecular tumor features. For the extent of resection for the category, we used the RANO category. Were applied to early, lesser than 72 hours after the resection, postoperative MRI. That's here our standard to determine the degree of tumor removal. And then we move to our results. 132 patients had multiple lesions, 60 multifocal and 62 multicentric. A mean of the years was 60 years, and almost 30 of the patient had a bihemispheric extension, and that's there is always option to resect the both side or just one side, or should we treat that with the chemotherapy radiation. The decision for the surgical resection was based on clinical status, the Karnofsky 70 or more, and tumor localization in relation to the eloquent areas. Concomitant treatment using temozolomide during conventional radiotherapy and followed by 6 cycles of the adjuvant temozolomide for the 5 days out of 28 days were applied in more than half of patients. Independent also, of course, independent of the MGMT promoter methylation status. We also use another chemotherapy, included different agents such as lomustine, as here known as CCNU, bevacizumab, procarbazine, as well the other regimes or section therapy, and also chemotherapy and radiotherapy alone, so without STU protocol was used just in a minority of cases, as you can see here. Adjuvant therapy was omitted in favor for the best supportive care in patients with initially underwent just a biopsy alone. And as I said, the decision to biopsy followed by best supportive care concept was stratified by age, preoperative Karnofsky performance scale, and respectability of the initial tumor. And the treatment according to STAP protocol was associated with prolonged progression-free survival and overall survival. Eventually, tumor recurrence was observed in all our patients. So tumors with multiple location involved more than one lobe in 72%, so more than 70% of all patient tumor localization were predominantly temporal, followed by frontal, parietal, deep lesions, insular, occipital, and brainstem. Tumor with multiple lesions affected both hemispheres more frequently than tumors with single lesions, and the number of contrast enhancing lesions was, we can say, similar in both of group multifocal and the multicentric. Just a second. And now we can have results regarding to our overall survival in the multicentric glioma. The mean progression-free survival was 12.4 months in the multifocal and 9.4 months in the multicentric glioblastoma. And we can say that mean of overall survival did not differ between multifocal and the multicentric glioblastoma. However, the tumor occurrence in the both hemisphere is not associated. What's very important point of this study is not associated with impaired progression-free survival and overall survival, as we can see in this graph. And our study showed that extent of resection was a significant predictor of progression-free survival and overall survival in patients with these multiple lesions. Great total resection, near total resection, and subtotal resection significantly prolonged progression-free survival, and overall survival compared to the biopsy alone is this group of the patient. And to a lesser degree, also partial resection did increase some part of overall survival, but gross total resection, near total resection, and subtotal resection were superior also to partial resection. When we talk about prevalence of the MGMT promoter, methylation we found was detected in 31% of all patients, and further progression-free survival was independent, while overall survival is dependent on the MGMT promoter methylation status. We perform also a multivariate analysis for overall survival, and overall survival is significantly influenced by extent of resection and the chemotherapy in our multivariate analysis. It's very important to say that treatment decisions for adjuvant therapy are based on the clinical status of patient, histopathological findings, including molecular markers taking current treatment guidelines into account, and the radiation therapy treatment was performed in all patients with a good to moderate ACOG. That I mean here 0 to 3. A total of so almost 70% of patients received radiotherapy, and hypofractionated radiotherapy in patients older than 70 years, conventional in younger patients also. Of those patients receiving conventional radiotherapy was used in 75% of patients. Important to say that we use that we have in all tumors, in all patients, we have a tumor recurrence, and we can at the end conclude that treatment paradigms for the multiple glioblastoma remains controversial, with the role of surgery to be clearly defined. Emerging evidence suggests extent of resection as a robust predictor of survival with these patients with the glioblastoma. Our data also support the surgery. We are so probably very aggressive in the glioblastoma in the management, and suggest our data digression from this traditional approach of biopsy only in the patients with multiple glioblastoma. And our study is very important because for the first time in the literature, our present data provides inconclusive insights into the influence of this multimodal treatment in the patients with multicentric or multifocal glioblastoma. This is some reference from the introduction, and good afternoon, and thank you for the minds. Yeah.
Thank you very much, Dr. Jakovic. This was very nice presentation, and somehow this subject is not very frequently tackled in the literature and at the conferences. Somehow people are not finding it so significant. I would like to ask a few questions for starting the discussion. First of all, do you have any biomarkers that have been found except the methylation, IDH or something like that, that have proved to have value in predicting or being different in this kind of category. I think that the first thing. The second thing is we have no clear margin between multicentric and multifocal. Do you have any difference between bilateral hemispheric lesions and unilateral hemispheric lesions to show? Because many people also use the so-called synchronous glioblastomas at the same time detected during the imaging. So that is a very, very interesting point. And the third and last is, do you have any comparison with your glioblastoma population, single lesion, single center, that has been in the same centers? Because there is always a little bit of selection bias according to the recruitment of the glioblastomas in different centers. So what is the real difference? Are these people performing much worse than the general GBM population or not? Sorry for loading you with so many things.
Well, thank you very much. I hope that I can answer all of them. So I will start with the last question. So we also compare in our groups single lesions and the multiple lesions, and our study said that if we resect this more than 80% of the tumors in the brain, we talk in the total cohort, then we will have improving in the PFS and the OS, in the overall survival, yeah? And our study said that there is no difference between hemispheric and bihemispheric. So we have the same result for the unispheric and the bihemispheric regarding to the surgery and regarding to the radio and chemotherapy. But what's very important to say that there is always in our study also, and that is one of the limitations of the study, because in the case that tumor was in the eloquent area, we didn't resect the tumor, and we calculate the whole volume for tumor. If we had, for example, 3 lesions, then we calculate the volume of all 3 lesions, but we resect, for example, just the 2 lesions because the tumor was in the eloquent, yes, and that's the problem, yes. Thank you.
And are there any biomarkers that you found, methylation I saw, that influenced a little bit?
Yes, we in this study we just focused on the methylation because regarding so according to the methylation, we made here a decision from the SU protocol for the adjuvant chemotherapy for lomustine. We wrote in our paper also just a table and the list of the biomarkers that we find, but we did not analyze because we do not perform the whole molecular analysis for all these patients. Yeah, and even that we have a group from the 2008 to 2020, and it's the same. We have the problems also in the classification because we have a 3 classification from the pathologist in the last 15 years. So that we made. Also, for example, our study was according from the last 2020 or 2021 classification, and also for the new RANO criteria, and that's also what's very important for the whole study.
Yes, thank you very much. Yeah, I think that was very important that you actually completed such kind of study to show us the outcome of these lesions. I don't see any question from the audience, but I would like to pass the baton to Professor Tani for comments and maybe questions.
Yeah, thank you, Dr. Dragan. So you are very incredible, so good results. So my question is, you in conclusion, overall survival is just influenced by the extent of the rejection and the chemotherapy, and yes. How is radiation result, effect. So have you ever
the 70%?
Mm.
The 70% of all patients received also stu protocol. That I mean that they had the radiation plus chemotherapy. But we said
I see.
Here we said that so overall survival, what extent of resection? Here we mean complete resection, subtotal resection, and near total resection, and also adjuvant radio chemotherapy.
Okay. And the extent of the resection. So to get the more resection volume. So how do you think about the intraoperative monitoring? So such as the awake surgery for the eloquent area and so on.
So that was one. Yes, thank you for your question. That was one of the limitations of our study. As I said, if the patient was, if the tumor was in the eloquent area, then we didn't, that we don't have the whole tumor resection, and we use in I think almost all patients in our department the with the tumor in the patient with the tumor in the eloquent area, we use neuromonitoring, especially in the awake surgery, and or if the tumor is in the central region.
Okay.
We use potentials. Yes.
Okay. So my last question. So last question is. Okay. So on the recent paper in my. So my recent paper has suggested that flarectomy, so less than the 60% of the resection of the tumor volume will be useful for the improving the surgical results. How do you think about the flarectomy, and how is the result of in your in your surgical result?
So you think lobectomy or?
Yeah, no, flarectomy.
I mean,
flare.
It is a matter of resecting the margins of the flare.
Yes,
image.
I understand. That's for instance. So we resect. So it's the reason why we at the beginning of the study we made the whole analysis of the contrast metal, contrast enhanced lesions, and also but flare lesions. So in our department we resect if we see the good contrast border. Then we resect just a contrast border because we have a very good oncology team who support the whole radiation therapy and chemotherapy. Because in Germany, the chemotherapy is also a job of the neurosurgeon. So that all is our job from our department. The second is that if we didn't see in the contrast MRI lesions, then we went to the resection with the flare MRI. So we resected the flare just in the case where we have no contrast enhancement on MRI.
Yes, thank you.
Yes.
Thank you so much.
Thank you very much. There is a question from India, from Dr. Chauhan, please.
Yeah, hi, Dr. Dragan. An excellent lecture. I just wanted to know, you did the MGMT, but did you not consider doing Ki-67? Because that will tell you how much is the ability of the tumor to propagate and reappear after your surgery. Did you consider that?
Yes, so we have also analyzed Ki-67, but as I said, in our department, the decision of the further treatment and chemotherapy goes always according to the MGMT promoter methylation.
Okay.
So we are always focused. We became always from pathologist Ki-67. but we also goes to the IDG wild type or not, and also or mutated, and the second is methylation, yes or no, and according to the methylation, then we go with the further treatment. In the last few years, we also began with the new generation sequencing, and I think that in next year we will publish our paper on this topic, yes, for the new generation sequencing medication tumors regimes.
I also have a very curious question, that where you have calculated the overall survival and progression-free survival. So the patients who died, what was the cause of death for them? Was it herniation of the brain, or was it chemotherapy side effect? What exactly was the cause of death finally?
So in Germany is that varies. So in Germany is we have a very often speech with the and the relationship with the family of patient and the family, and we always all together, our department, and with the family of a patient, we always decide that what is the best care for the patient, and we always talk with the patient, because as I say that in Germany the chemotherapy and oncology is a part of the neurosurgeons, and then we see these patients every day in our outpatient clinic after resection also, and we always talk when we have to stop with the chemotherapy. And in all patients we have this group, the best supportive care group is when patients say that he don't want, and our patients very often said, I think that I cannot do that anymore, and I don't want more chemotherapy. And so is the reason. So I cannot say, because we make in this patient we make all every 3 months MRI, every 3 months MRI, or if the patient had the progress or seizures or some new symptoms, immediately MRI. But we don't analyze if we had herniation, because often the patient had supratentorial tumors, and just less of them had in posterior fossa, and at the end the patient died because of progress of disease. Yes.
Okay, thank you. Thank you.
Thank you very much.
Thank you very much, Dr. Jankovic. If there are any other question or any other comment? Thank you very much for your presentation. It was really very valuable for our audience. And now we have our third speaker, that is Professor Yang from China, who will be talking about surgical technique. And that will be just a very valuable practical demonstration and discussion from him, so we can really provide some clues on the work of our young neurosurgeons. Professor Yang. Is Professor Yang available? Professor Yang?
Professor Xinyu Yang.
Professor Xinyu Yang?
Professor Xinyu Yang? Yes, he is here.
Professor Yang?
Professor Xinyu Yang, please unmute your mic, Prof. Can you hear me? There is no sound, Professor Xinyu Yang.
We are not hearing you.
I cannot hear you. Can you make sure?
Can you hear me?
Yes, now we can hear you. Yeah.
Yeah, okay,
yes.
I take out myself.
Welcome. Yes.
Yes, now.
Welcome.
Yes.
Welcome.
Okay,
you have the floor, please.
Sorry for the trouble for everybody. Okay. Okay.
No problem.
And this is my great thanks to Professor Yuko Kato for her allow me to participate for this valuable webinar. And my presentation will be talking about the surgical techniques. Let me share my screen. So, okay, can you?
Okay, fine.
Okay, let me start. Today my presentation, the title of my presentation is Sharp Dissection and Drilling Technologies in School-Based Surgery. To our acknowledge, the school-based neurosurgery mainly including two diseases. One is tumor, another is aneurysm. The objective of the school-based surgery is to remove the tumor or place clipper without injury to the surrounding tissues. Those tissues including brain, nerves, arteries, and veins. And for all the approaches to the lesions, we must transfer from the skin, muscle, dural, and arachnoid memories. During the approach, we have two major techniques we need to train. When I was a young neurosurgeon, I was trained by my teachers, and I studied from a lot of world-famous neurosurgeons. I saw them how to drill the bone and make a very wonderful sharp dissecting for exposure of the lesions. So classically, there are about 4 points or 4 directions for approach. One is terminal and lateral subfrontal approach. Another is subtemporal or Kawase approach.
We got disconnected, it seems. You can wait for him 5 minutes. Let me join us.
Yeah, we have to wait. We wait because he disappeared completely.
He mentioned earlier that his internet was unstable. I think he should be joining back. So
Somebody can send me an email because I don't have a way to contact him.
yes, of course, we can send.
But we are waiting for him.
Ben Sensei, do you have his phone number? Prof. Sinyu Yang's?
No, I don't have his phone number. No, I don't have his phone number or WeChat.
Okay.
Sorry, I saw your email, but it seems there's no reply yet.
Yes.
I just sent an email to him, but no reply from him. So. I think maybe Dr. Shubin, he has.
Maybe poor connection, but I'm not sure. Let me try to reach Shubin by reach.
Hello, seniors.
Okay. Hello, how are you?
Hello, Professor Shifei.
Very nice to see you. I'm Shifei. I'm a Professor Yang is my master supervisor. So
Okay.
yeah, so maybe he's some logging over the internet. So I have a message to my supervisor by WeChat. So please give me a patience, give my professor a patience. Thank you.
Thank you. Thank you very much.
Now I'm in Germany.
Thank you so much.
Thank you very much.
Maybe you can share
Thank you.
Yang's WeChat ID to Dr. Ben.
Yeah.
Thank you.
Thank you.
Professor Kato?
Yes?
Yeah, I have a special guest here who want to say hello to you.
Yeah, who is he? She or he?
He is Professor Sanford.
Yes, Professor.
Yeah.
Oh, hi, how are you?
Hello.
Hi, how are you? Nice to see you.
Professor,
How are you?
very nice to see you.
Hi. Wait.
How's everything?
That you can hear.
Hello. Can you hear me? Professor.
Yes, we can hear.
Hello.
Yeah, Professor, nice to see you.
Hello, Professor Sinyu Yang. Welcome.
Welcome
Yeah,
back.
we have the Rosemary course in Taipei. Yeah, and that's why I invited Professor Sanford to say hello to you.
Okay, thank you so much.
He will call you very much. Thank you, Professor.
Thank you. Thanks so much.
Ben Sensei, Professor Sinyu Yang.
And just Sachin and Raja, you are welcome to Taipei.
Yeah.
As I promised,
Hi.
yeah, you are welcome to our courses, especially in November. We have the
November.
Society.
Yes, Rotten Society. Yes. Thank you very much for your invitation.
Yeah, Professor. Please give us a talk. Yeah.
You get to see your face.
Yeah. Thank you very much.
Thank you so much. Thank you.
Thank you.
Please take care, Dr. Ben.
Sure. I'll send an email. Yeah. Okay.
Hi, everybody. Professor.
Hi.
I'm coming back.
Yes. Ready?
Yes.
Yeah.
Professor Yang.
Yes, I'm coming back. I lost my internet just for a minute. Sorry for trouble.
No problem. Thank you so much, Professor.
Let me continue my presentation.
Of course.
Yes, please.
Okay, thank you. Okay, is it okay?
Yes.
So
we are waiting. Yes, it's okay.
Okay, let me continue with my presentation. For young neurosurgeons who performing aneurysm clipping or for the tumor removal, we need perform the technologies of drilling and the sharp dissecting. This video shows that with scissors we can make sharp dissecting for aortic membranes. So although we have the scissors, but not enough. We need a microscopy and the lightning to see what's underneath these scissors. So with the carefully watching by microscopy or endoscopy, we can see the tissues very clear, and the only thing we need to training is we need a stable hands and stable to hold the scissors, to cut the membranes, not the injury to the arteries when we dissecting for the terminal approach. So that's the point. Was we need training for young neurosurgeons. This is the very important step when we make the dissecting, so we can see the anatomical structures. The first cases I present here about the dissecting and the drilling is the from the terminal approach for clipping anterior internal carotid artery aneurysms. This is a small aneurysm from ophthalmic arteries, and we need to remove the ACP to see the neck of new aneurysms. So this video I have shown presented in another meeting. So maybe some professors have seen these procedures. So I would like to go through it very fast. And so after dissecting for the ironic membranes, we need to drill the ACP. So we cut the dural matter and cover it on the optic nerve, so we can have a cover for optic nerve when we drill the ACP. So first we use the cutting drill. The cutting drill is much faster when we use it, but it's also dangerous to the surrounding tissues. So when we remove some of the bones of the optic nerve roof and part of the ACP, we need to return to the diamond drills. So another important thing when we drill for the approach, we need cooling it, because when the very high speed drill to remove the bone, there are a lot of heat product by the drill. So we need cooling it steadily. And another benefit of cooling with water is we can clear the debris of the bone immediately, and we can have a very clear field. So after drill the bone, we can mobilize the anterior process. Usually there will be some bleeding from the cavernous sinus. We just put some gauze, we can stop the bleeding. So after remove the ACP, we can see the neck of the aneurysm. So we can easily clip the aneurysm. That's what we can see from the beginning of the procedure. After we remove the ACP, we can expose the aneurysm neck, and we can perform the neck, perform the clip. So with very small craniotomy and with the drilling techniques and with microscopy, we can clip such small aneurysms. Another approach is the retrosigmoid subtopical approach. Usually we use this approach for acoustic neuroma, and to remove the acoustic neuroma, there's three major approaches, but for the commonness and for the easily from the retrosigmoid approach is much easier. But for small tumors in the internal auditory canal, we need to use the drill again. So after dissecting the ironic membranes, we use the cutting drill first to make the bones, to remove the bones, and with keep steadily irrigate the cold water, so we can safely remove the bone without thermal injuries. So this is another point for training for young neurosurgeons. First, we need a stable hands to holding the drill and explore the tumor. Another important point, when we remove the tumor, we need with the scissors and the dissectors will be the better, not use the bipolar. We take the tumor by piecemeal, and even almost the tumor was in the internal auditory canal, we can remove it. So after the surgery, post the surgery, from the CT scan, we can see how much the bone we have removed for the patient. Here, another case of acoustic neuroma, and we remove the tumor with forceps, and the less use of the bipolar, the better the results. So we can save the facial nerve for the patient. So we drill for the internal auditory canal with the drill. This time, once again, we need stable hands. And when we drill it, another thing to keep in mind is to keep cooling, to make sure that there are no thermal injuries. So after opening these internal auditory canals, we can see the tumor in totally, and with very nice seeing how the whole procedures and very safely to protect the facial nerve. So this time we can see the underneath the tumor is the facial nerve. We use the stimulator to identify the facial nerve. So we totally remove the tumor and preserve the facial nerve. So the first important step is the drill the bone of the ICA. So this, after the tumor removed from the CT scan, we can see that how much the bone we removed. And another case for retrosigmoid suboptical typical approach is the jongular tumors when we remove it. It's not necessary for us to drill too much bone for the patients, but the sharp dissecting is another important thing. When the tumor have a surface between those nerves, this is acoustic nerve and the facial nerve. But between the nerve and the tumors, there's ironic memories. So we need to remove the tumor without bipolar. We can remove the tumor by sharp dissecting to preserve the surrounding nerves and keep the function intact. So we need to keep in mind that either the drill or the bipolar, they can prevent the tissue damage by cells. So we can see we go through the ironic membranes and the sharp dissectings. We can remove the tumor and preserve the nerve. And the third approach we need training is the atlanto and occipital area surgery. Usually there are three surgical approach, which are far lateral approach, extremely lateral approach, and the transcondylar approach. And so we need to put patient in park bench position and open in dissecting in special anatomical procedures like drill the bone and preserve the vertebrate arteries. This is a case of atlanto-occipital schwannoma, and we can see here is the vertebrate artery, the second segment of the vertebrate artery we dissected. But to see, if we want to see the tumor underneath, we need to remove all the bones around here. So after we identify the vertebrate arteries, we need the second step. We need to remove all the bones covering the tumors. So it's very important to cooling down the drill and to protect the surrounding tissues. We can see the bump of the vertebrate artery. We remove the occipital and the C1 arc of the brain. So after opening, we can see the vertebrate artery is just underneath the dura, and this is the C1 nerve. Because the tumor is in the frontal and the lateral part of the brainstem and the C1 spinal cord. So we remove the tumor from the very small space, step by step, and in piecemeal. So this is the C1 nerve of the spinal cord. So sharp dissecting not only refer to the memory, ironic memory dissecting, also refer to the remove the tumor in piecemeal, and the less use bipolar, the better result of the patient. So we can see even the perforator of the vertebrate artery is preserved by this means. So the blood supply to oblongata and the cervical spinal cord is preserved. So we can remove the tumor by the far lateral approach, but we need to keep in mind to preserve the nerve, the arteries, even the perforators from the vertebrate arteries. Yeah. So this post the surgical CT scan and MRI scan, we can see the tumor is totally removed, and we remove the bones covering the tumors, and we can have a space to remove the tumor. And then finally, the last approach is the subtemporal or Kawase approach from the middle middle fossa to the cleavage and to say the basilar artery or the brainstem. So here we can see that this is the case of a ruptured basilar artery top aneurysm because the geography of the aneurysm is not suitable for coiling or interventional treatment. So we perform subtemporal approach for the ruptured basilar artery. This is a from, oh, sorry. Let me show the. Let me play from the screen. Okay. So by the subtemporal approach for the basilar artery aneurysm, we need to cut the temporal first. So we see the cochlear nerve first. Because it is the rupture aneurysm. Oh, sorry. Because it's a rupture aneurysm, there are cerebralic hemorrhage. So step by step, we identify the oculomotor nerve and the basilar arteries. So we put a temporary caliper in the basilar artery. We keep in mind to preserve the perforator from the basilar arteries. And then we return to the basilar tap. We can see the oculomotor nerve and the 𝑃𝒂𝒏 and the P1. So here we very near to the aneurysm neck. So after identify the neck of the aneurysm, we put a caliper here. So we can see the controllator P1 and the neck of the aneurysm, even if this time the aneurysm rupture again, but we already put the caliper in place. So we remove the temporary caliper from the basilar artery and finish the surgery. And from the picture, we can see that from subtemperature approach, we can approach to the third and the fourth nerves, and we can see identify the PCA and the 𝑃𝒂𝒏, and we can see the aneurysm neck over here. So the patient recovered very good. So from the post surgery CT angiography, we can see the caliper right into place. And another case for illustration for the subtemporal or Kawase approach is the meningioma of the cavernous sinus. Is not too very big one, but we perform the subtemperature approach to remove the tumor again, combined with the Kawase approach. So we see the cochlear nerves first, and after sharp dissecting the memories, we see the tumor, the roof of the tumor, and the basilar of the tumor. So we remove the tumor in piecemeal, but after remove the tumor between the tantrum and the petrol rash, here some debris we need to drill where the Kawase approach to remove the tumor totally. So even in the inside the tumor and remove the bone, we can get more space for the purpose of totally remove the tumor. And the same the requirement is the same to cool down the drill to prevent the thermal injuries, especially the surrounding tissues are very important because the third, fourth nerve and the puntings is around here. We need to keep in mind to remove all the tumor without injury to the normal tissues. So we see the basilar artery again, which means we remove the most part of the tumor. So from the picture, we can see after remove the tumor, and we see the basilar artery and its perforators and the puntings is just behind the basilar artery. So we can remove the tumor by drill for the Kawasai's triangle, and we have the more space for the remove the tumor. So in summary, and for training for young neurosurgeons for scope-based surgery, we need to learn anatomy, and we need release the CSF to relax the brain. We need good optical magnificence, both with microscopy or endoscopy, and we need training for drill and micro scissors. When we use it, we have to avoid the thermal injury, and we need accurately cut the ironic memories with scissors and take care to surrounding tissues. And for young neurosurgeon, we should always remember that the patient is the first, and we need learning the acknowledges and the training, and with hard working and with our confidence. So that's my presentation. Thank you for your attention. Thank you very much.
Thank you very much, Professor Yang, for your very instructive presentation and the well-illustrated nice surgeries that you have shown.
Yeah.
I would like to welcome the audience for any questions meanwhile. And I see...
Let me stop my screen sharing.
Yes. Yes, Ben, you have raised your hand.
Yeah, I'm
yes.
looking for
hello, Professor Yang. Hello.
Hi. Okay.
Professor Yang, I'm Ben from Hong Kong.
Thank you.
Okay. Yeah, I'm so glad to meet you again here, and
yeah, so nice to meet you again.
China, and yes, and I really enjoy your talk a lot. And I want to ask, so do you think in high widening jugular bulb is a contraindication to drill the IAM? What do you think?
Excuse me, well, my voice is very slow. Will you please again?
Okay. I asked my question again. So do you think high widening jugular bulb is a contraindication to drill the IAM? Any experience in your series to drill the IAM in high widening jugular bulb?
Sorry, the internet is not so good.
我说普通话可以吗
？Okay, please.
Okay. 这是如果比如说那个 jugular
bulb， 这是比较
yes.
Okay, so in Chinese, please. In Chinese, please.
Yeah. 就是如果 jugular bulb 的位置是比较高的时候，就你会觉得你可以安全的drill那个 IAM 吗？
Okay. For the jugular bone, I'm not too many. I don't have too many experience, but to my opinion, if we have some tumors in the skull base, and we can remove the tumors which comprise to the brainstem or comprise the brain nerves. We remove the first, and if we after remove that, the second choice is that should we remove the tumor totally? If the possible, without less injury to the patient, we can drill the bone and remove the tumor inside the bone, or covered by the bone. And if the drilling is too dangerous, if we will injure the sigmoid sinus or injure some important nerves like 11, 10, or 9, we should preserve it. And we have another choice. We have the radio surgery, we have a gum knife and X knife, and so many choices. So I think preserve the function is the first. So that's my opinion.
Thank you. Thank you so much.
Okay.
Thank you, Professor Yang. Any of the discussants, comments? What about
may I can I ask a question?
Yes,
okay.
please.
Yes, please.
Okay. Thank you, Professor Yang, for your excellent technique and philosophy for the direct surgery. So, my question is about the anterior crinoidectomy. So, how did you experience the visual dysfunction, such as visual field deficit or visual? Yes, because I usually the intradurally crinoidectomy. I usually familiar with ultrasonic bone curette to avoid the heat injury for the optic nerve dysfunction. So, or otherwise, I usually use extradural crinoidectomy with no drill technique. So, how do you experience the visual dysfunction, the intradural crinoidectomy?
Yeah, I see. Thank you, Professor Anthony. I see your questions, and it's a long history topic of extradural or subdural approach to remove the ACP. So, to my opinion, and to remove the ACP, and because I remove the ACP most of the time, I remove it is for aneurysm. For the clinical segment internal carotid artery aneurysms, and for the purpose to safely to clip the aneurysm, and when we drilling the bone, there's some conditions may be happened. The aneurysm may be ruptured. So when I drill the ACP for the purpose of clipping pyroclinic aneurysms, the first I usually open the neck of the internal carotid artery in the neck. So the first definitely is not necessary, is no relation to the optic nerve, but this is for the control, for the primary control for the aneurysm, and so for this purpose, I never do extradural the ACP removement for aneurysm cases. So most of my case is subdural remove of the ACP. So the first is very important thing when we have a control of the blood of the internal carotid artery. The second very important point is to prevent a SEMO injury to optic nerve. If the SEMO, the heat is very high, and is definitely it will injure the optic nerve. So the only thing we can do is to irregulate. We inject silence continually without if there is no water, no drill. That's my requirement to my residency. When we have on the table, when we drill the ACP, I always ask my residency to tell me he's run out of water before actually run out of it. So I will stop the drill when they need change the surrounding we have new waters. So water is very important. To my opinion, we need to inject waters to the drill to cool down when the drill is working. And the second point is we need to use the diamond drill. The diamond drill is also diamond drill produce the same heat with the cutting drill, but the diamond drill we can go slowly and we have the dural covering the optic nerve, so we can keep that layer of dural intactly. That's my opinion. Thank you for your question.
Yeah. Thank you. Thank you so much.
Thank you. Dr. Shahnawaz?
Thank you, Sensei. Excellent presentation. I have just one question. Sir, most of the time, we young neurosurgeons, especially myself, hesitate to cut the tent when I go subtemporal transtentorial approach to preserve the fourth cranial nerve.
Yeah.
So any tips at which point I may avoid to injure fourth cranial nerve during transtentorial approach?
Yes. When we go through the subtemporal approach or the Kawasaki approach, the first nerve we will meet is cochlear nerve. Absolutely, because this nerve run from the back of the brainstem and go along the tendon, the edge of the tendon. So we need to cut the tendon first. So by sharp dissecting, because the tissue is different, the tendon and the nerve is different. Nerve is soft and is kind of learn under in the CSF. So when we cut the tendon, we need to make a tension of this dural matter. This dural matter, we can have the different feeling of the dural matter and the nerves. Even we cut the tendon with a knife, and the nerve can avoid the knives. So we need to cut the tendon step by step, one by one, not cut the tendon once in a time. Repeat the cutting actions small by small. Okay, that's my my opinion.
Thank you very much, Professor Yang. Thank you.
Okay.
And, maybe we'll have to listen a little bit finally from Professor Ahmed Pirzad, whom we couldn't hear as a discussant today. Well, you're welcome, Professor Pirzad, for your comments for this evening.
Salam, konnichiwa.
Konnichiwa.
Good evening. Thank you. Konnichiwa. Thank you very much. It was a great presentation and great webinar, and especially Professor Yang presentation was very useful and with learning purpose and step by step. Thank you very much, and it was very good, and thank you for organizing this webinars, and especially for young neurosurgeon, it's highly effective. Thank you very much. Arigato gozaimasu.
Thank you. Thank you very much, Professor Pirzad, for your comments. I don't see any further raised hands, so I would like to invite Professor Kato to do some concluding remarks for today's webinar.
Okay, thank you very much. So first of all, Dr. Yang, thank you very much for excellent talk. And just I would ask one thing is which nerve, cranial nerve, the weakest cranial nerve from your vast experience.
Which nerve for what?
Weakest.
Weakest, which is
I mean,
most
fragile. Yes.
Fragile. I think the most fragile nerve may be from if we put too much force, too much pressure, every nerve is fragile. So, from my opinion, and it depends on the size of tumor. If we have very giant Atlantic occipital tumors, the number 9, 10 is the most fragile. For me, I can't preserve at least 2 nerves with very big tumors. It's very difficult.
Thanks so much. And one more thing, that Dr. Yan, maybe you can make some announcement that you will have international congress in your future in Tianjin.
Yes. Thank you, Professor. Give me the opportunities. So we are trying to organize international conference in this summer, and that's a conference focused on complication of neurosurgery. That's maybe the purpose is the teaching and the discussion for young neurosurgeons, and as well as for the experienced neurosurgeons. So, to my understanding, complication cannot be avoided, but we can avoid some of them in this time. And so this summer we will have the great honor to work with Professor Kiki Tullier from Mumbai. He's the organizer for the International Complication Conference. He has held the meeting 4 times in Mumbai. This is the first time he organized the meeting outside India. We are very honored. We are very honored to have the opportunity to work with him. And we also have two conference presidents who are my classmates when I was studying in Japan, in Tokyo. That's famous Russian Japanese working in Japanese is Michael Chenov, and another is Kubota, who is special in functional neurosurgery. So all three are same age. We study under the direction of Professor Holly. we have more than 20 years fellowship. So we hope to organize an international conference about the complication this summer, and it's my honor and many thanks to Professor Kato. I have the opportunity to invite all the professors and the young neurosurgeons go to Tianjin. I think we'll have a very plenty conference. Thank you, Professor. Thank you, Professor Kato. Thank you for your allowing me.
ありがとうございました。So thank you very much for today's the webinar. I think Yagi Sensei is very basic things, especially related with the aneurysm and hemodynamic things. And also the Dragon, he is very clever, the young neurosurgeon. He always think about the paper writing. So I think his enthusiasm to learn and work hard is very, very important for young doctors. And also finally, the Dr. Yan is expert of the skull base and also vascular neurosurgeon. So we learned a lot from 3 doctors. And thank you very much, Otai Sensei, for your very valuable comment, as always. So thank you so much. Otai Sensei, thank you so much.
Thank you very much. I think we can conclude with this, our webinar today. It was really very, very efficient. So thank you very much to all participants. And if there is any announcement, Ben, you're welcome. Otherwise, thank you very much and very good night. Thank you.
Okay, good night.
Thank you so much. Thank you so much.
Meeting in Taiwan.
Have a good night.
Bye.
Thank you very much.
Thank you so much. Thank you, Professor Yang. Congratulations.
Okay,
Yeah, sure.
Thank you very much.
Sure. Thank you so much.